Hello, everyone. Welcome. We're so glad that you could join us today. My name is Preeti George, and I'm the project director for SAMHSA's National Training and Technical Assistance Center for Early Serious Mental Illness, also known as the ESMI TTA Center. We're so very pleased to welcome you to our webinar on partnering with crisis services in early serious mental illness programs. So we'll get started. We'll have some few introductory slides as people log in and get registered and get situated for the webinar. So I'll just go through some of these initial slides here. We have a disclaimer slide that the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, or CMHS, the Substance Abuse and Mental Health Services Administration, or SAMHSA, or the U.S. Department of Health and Human Services, HHS. So we have a few housekeeping notes before we get started. This presentation is being recorded. During the presentation, you are welcome to submit your questions through the chat or through the Q&A feature. So please feel free to do that. We welcome all of your feedback. We will be making the presentation slides available afterwards. We'll be sending it out through email, and you'll be able to have a copy of those for your records too. We have a number of individuals who have the word ESMI TTA Center next to their names on the Zoom platform. So you can feel free to reach out to any of them if you have any questions or you need any assistance throughout the webinar. Okay. So this slide here, you may hear the term ESMI throughout the presentation, and that refers to the term early serious mental illness. This is a working definition on the screen here that is used by SAMHSA of the term ESMI. And essentially, ESMI refers specifically to the initial period of onset of diagnosable mental, behavioral, or emotional disorders that have an impact on people's interpersonal, academic, or occupational functioning. So you'll hear that term throughout, and just for your reference, that's what we mean. For our session today, we will be soon introducing our guest speaker, and he will lead you through a presentation about crisis services and ESMI programming. And then we'll end with the question and answer session and closing remarks. So that's what we'll be doing today. And now I'm so pleased to introduce you to today's speaker. So Dr. Nicholas Brightboard is the Charles F. Sansbaugh Professor of Psychiatry, College of Medicine, Distinguished Professor, and Vice Chair for Community Behavioral Health in the Department of Psychiatry and Behavioral Health at The Ohio State University, where he serves as Director of EPI-Center, which is the Ohio State University Psychosis Program. He serves as a senior collaborator for the Global Burden of Disease Study and is a former member of the American Psychological Association Task Force on Serious Mental Illness, Severe Emotional Disturbance. To date, his research has been cited over 100,000 times and has been funded by agencies such as the National Institute of Mental Health and the Substance Abuse and Mental Health Services Administration. So we are so pleased to welcome Dr. Nicholas Brightboard.
Well, thank you. Wonderful to be here. I appreciate the introduction, and a special thanks to whoever I saw it flash quickly in the comments said "Go Bucks." We are all enjoying how we're doing after this last weekend here. So for today, we're going to be talking about the intersection and utility of collaboration between crisis services and early psychosis programs here, specifically programs serving people with first episode psychosis and those at clinical high risk for psychosis here. So we'll talk about that collaboration here, some thoughts and benefits around establishing pathways for referrals between early psychosis clinical programs and these crisis services, and then also briefly talk about some of the best practices for addressing crises that may emerge in clinics serving people with first episode psychosis or those at risk for developing a psychotic disorder. Next slide, please. So quick definitions, just so we're all on the same page here. Crisis. What we're thinking of here is for our individuals with first episode psychosis or those at clinical high risk for psychosis, a crisis is a moment where they experience something that creates distress that is greater than their ability to cope with right here. Clinical high risk refers to individuals who don't yet have a psychotic disorder, but are at risk for, or at elevated risk for developing one in the future. Sometimes that gets abbreviated CHRP or CHIRP. And then our first episode psychosis term is always a bit of a misnomer. It's not people who are experiencing really their very first symptoms of psychosis, but people who are early in the course of a psychotic disorder. Programs define this differently. Sometimes they might say within the first 2 years after symptom onset. Some go up to 5 years. It depends. So these are the key terms that we'll be talking about today, and want to start off with some quick definitions to make sure we're all on the same page. Next slide, please. So when we think about crises that individuals with psychotic disorders or those who are at elevated risk to experience psychosis may experience, the largest one that we worry about here, of course, is suicide. And rates of suicide are elevated among individuals with psychotic disorders compared to people without. And that includes both people with our schizophrenia spectrum disorders, but also people with mood disorders with psychotic features. The increased risk of suicide is greater in those two populations than among individuals without these disorders here. And the stats of how this play out are in many ways pretty terrifying here. Somewhere between a quarter to a half of individuals are estimated who experience psychosis as part of one of those disorders are estimated to attempt suicide sometime during their life, and approximately 5 to 10% die by suicide during these illnesses. Next slide, please. Now, when we look at psychotic disorders here, and we look specifically at individuals with first episode psychosis, one of the nuances we see is that the risk of suicidal ideation and behavior not only is elevated among individuals with first episode psychosis, but appears to be even greater earlier in the illness than later on. So when we're working with individuals with first episode psychosis, when we work with anyone with psychosis, we should be concerned and paying attention to risk for suicidality. But we should be particularly thoughtful about that when working with individuals with first episode psychosis, because that risk is even greater during that specific time of illness. And we've seen this shown repeatedly across various trials that have been done both in the United States, such as the RAISE and On Track New York, but also outside of the United States with the OPUS trial and the PARMA trial, both done in Europe. High rates of suicidal ideation behavior clustering early in the illness. Next slide. And when we think about early in the illness here, really the risk seems to be greatest in the very short period after a person's first symptoms of psychosis start. So Aubrey Moe, a professor here at Ohio State and part of our team here at Epicenter, looked at this issue of when is the peak risk of suicidality among individuals with first episode psychosis. And she did that by looking at Medicaid claim data, national data set here, looking at over 19,000 adolescents and young adults, identifying folks who between 2010 and 2017 had their first onset of psychotic symptoms, and then followed them in the claims to see if any claims were submitted indicating one of the self-harm codes that can indicate suicidal behavior, but can also capture people who elaborate in non-suicidal self-injury as well here too. And what she found is not only were there high rates of this self-harm code being billed for individuals with first episode psychosis, but the greatest risk happened within the first 3 months after they received their diagnosis. So when we're thinking about there's a high risk for suicidality among individuals with first episode psychosis, that is true, but the greatest risk is very, very close in those first few months after the diagnosis happens right there. So as individuals enter these programs here, this may be the greatest time to be really assessing and addressing suicidality. It's also part of the reason why it's so important to work to try and get folks into programs, those who want to, as quickly as possible to help address first episode psychosis, so we can catch them during that tight window there where the risk of suicidality is the greatest. Next slide, please. So even though suicidality is greater in individuals with psychotic disorders than those without, and it seems to be even greater in first episode of psychosis compared to long-standing illnesses, we can even now look at individuals who are at risk of developing psychotic disorders, those who are called being at clinical high risk for psychosis here. And here, even in this population, before the full onset of frank psychotic symptoms here, not only do we see elevated risk of suicidal ideation and behavior compared to individuals without psychosis, but we actually see suicidal ideation in this population that's even greater than the individuals with first episode psychosis and individuals with long-standing psychosis. Dr. Heather Wassler and Dr. Maggie Manges from our team here at Epicenter just published a paper on this right here, where they looked at rates of ideation behavior among individuals at clinical high risk, those with first episode psychosis, and those with long-standing psychotic disorders, meaning that they are beyond the first episode here, and found that the risk of suicidal ideation over the last 2 weeks was even greater in our clinical high risk folks here than those with first episode. This paper, I'll say, is now just very recently accepted for publication in Early Intervention for Psychiatry, if anyone's interested in checking it out. But what we can take from all this here is crises are, and especially suicide, is a significant concern early in the course of psychotic disorders here. Even before the onset of frank psychotic symptoms, just when people are showing the early risk symptoms here. And for those of you working at either CHIRP or FEP clinics, these will be things that will be coming up probably more frequently than not in the individuals that you're working with here, and it's good to be prepared to know how to address them. Next slide, please. So what contributes to these high rates of crises? Why do we see early in the course of the illness this greater likelihood that individuals are going to have these moments where the challenges that they're experiencing in the world are exceeding their ability to cope with them here and leading to things such as suicidality? Next slide, please. So part of the concern here, part of the reason why we may see these, is that if we look at the risk factors for suicidal behavior, and we look at the risk factors for being at risk for psychosis or developing a psychotic disorder, there's a lot of overlap between these things. We see challenges with effective coping skills, managing mood, reduced peer support, isolation, and loneliness. These are all things that are both risk factors for psychosis and risk factors for suicidal behavior. And the fact that these overlap may explain why we see high rates of crises among individuals with psychotic disorders. Now, what this doesn't explain, though, is why do these seem to cluster more often early in the course of the illness? And while they're still prevalent later on, they're at least reduced in their frequency. Next slide, please. Drs. Adam Miller and Mitch Prinstein put out a really wonderful paper that I think was not really addressing psychosis specifically, but addressing high rates of suicide among adolescents and young adults, that I think paints an important picture of why we see these elevated rates, crises, and suicidality that cluster early in the course of psychotic disorders. As many of you know, psychotic disorders emerge in late teens and early 20s. So we're getting that sort of adolescent young adult period here. And that also tends to be the time when rates of suicide tend to be the greatest right here. Now, some people a while ago hypothesized, well, maybe that's because individuals who are adolescents struggle with managing impulsivity. And that struggle with impulsivity may put them at greater risk here to engage in risky behaviors, suicide being one of them. And it is true, we do see high rates of impulsivity among individuals in the adolescence. But the puzzling thing was, if it's because of sort of brain development, and we're thinking of brain development as happening sort of continuously, you would imagine that even young kids, like 5 and 6-year-olds, would struggle with impulsivity even greater than their teenage counterparts and engage in more risky behavior. But we don't actually see that. We see that the rates of risky behavior, including suicide, cluster in this sort of adolescent young adult period here. So what is it about that period developmentally that may matter? Next slide, please. So Miller and Prinstein in their model, which was not about individuals with psychotic disorders, just about adolescents in general and young adults, highlighted two things that they think may contribute to this elevated rate of suicide that clusters in this developmental time period. One thing that happens is this is a period of time where people are going through important developmental changes. They are navigating from moving away from their parents and family as their primary social support to beginning to have peers as their primary support in the world right here. And not surprisingly, as you are learning that skill and navigating these new relationships, not everything goes smoothly, meaning that there is a spike in the amount of negative life events that that teenagers and young adults experience during that time as they navigate these new relationships and how they're going to work. That occurs in adolescence and young adulthood, and then as they master that skill, it becomes less and less frequent here. So one thing Miller and Princeton point is, okay, we've got an increased rate of stressful life events that's happening in this young adulthood, adolescent period. Then they also looked at biological research, largely coming from the really seminal work of Dr. B.J. Casey, who addressed that question of, if we're seeing more impulsive behavior, including suicidality in adolescence, why is that? What's happening in the brain in that point here? And what Dr. Casey demonstrated that really changed our understanding of neural development was that there are certain parts of the brain that improve sort of continuously at a steady pace, and they develop fully. And then there are other parts of the brains that start developing very quickly and kind of then taper off right here. And if you imagine a graph of that right here, you'll have parts of the brain, in particular, areas that manage stress response in the amygdala, that develop very quickly and almost hit full development in this adolescent young adult period here, whereas more frontal lobe areas of the brain develop at a slower pace. So you got a curved line and then a straight line. And there's the biggest difference between those two is going to be right around that adolescent young adulthood period there, where we have fully functioning stress response systems here, but a frontal lobe that is still developing, not fully developed, and is not fully able to cope with the challenges of stressful life events that's happening here. So what Miller and Prinstein suggests is that adolescence in many ways is a perfect storm. We have individuals who are more likely to experience negative life events due to the normative developmental events that are happening during that time here. And their biological resources to navigate those challenges here are at their least strong right here. And that, they have hypothesized, may be why we see this greater risk of suicidality among individuals in adolescence and young adults compared to really many other time periods here, except very older age. We, in a book that Jason Schiffman and Leslie Horton and Scott Woods are putting out about being at risk for psychosis, we reviewed this data and asked, does this model from Miller and Prinstein maybe shed some light around why rates of suicidality are particularly high among individuals with first episode psychosis and clinical high risk who are in this young adult adolescent period here? And what we found was that this model really holds true for this group as well here too. Individuals at clinical high risk and young adults with first episode psychosis are at greater risk for experiencing negative life events, not just compared to people without psychosis, but also compared to young adults without psychosis. So if young adults with psychosis are having a lot of negative events, individuals early in the course of psychotic disorder are having even more. It's elevated in that group here. Also, when we look at these biological systems that regulate how we respond to stress and our ability to cope with stress right here, in individuals with psychotic disorders, as part of the illness here, we see an even greater reduction and slower development of the biological systems that are designed to cope with and respond effectively to acute stressors here, compared to adolescents without psychosis here. So we've hypothesized that this model of Miller and Prinstein may hold true for individuals with psychosis here, that it is the perfect storm of adolescence where we have greater stressful events and reduced ability to cope with them, but that among individuals with psychotic disorders, those are even greater than you would experience among those without. And this may be why we see this clustering of crises and suicidality happening so early in the course of the illness and then tapering off as it goes on. Next slide, please. So with all that in mind, how do we support individuals with first episode psychosis and those at clinical high risk when they're dealing with a crisis here? SAMHSA has recently highlighted their model for what an effective crisis system should look like here. And they see it as comprised of these three components here: someone to contact, someone to respond, and a safe place for help. Next slide, please. So someone to contact, these are our crisis contact centers here. These are places that people can reach out to get developmentally appropriate brief screening and intervention to assess their risk for self-harm and suicide here. The one that people are probably most familiar about here is 988, a really wonderful national service that is now available to support individuals who are experiencing a crisis and have someone that they can talk to 24/7 during the day. Next slide, please. When we think about someone to respond, these are our mobile crisis and outreach services. These are people that can not just talk to you on the phone, but actually come to where you are to help you with the crisis that you're experiencing here, and if needed, help you get to the services you need right here. There are a number of different models of these mobile crisis teams. Some of them are comprised solely of behavioral health practitioners who come out to meet individuals where they are in the community. Some states will have a combined behavioral health practitioner and other first responders, whether it be EMTs or law enforcement, that collectively will go out to help individuals. And then there's also now MRSS services, mobile response and stabilization services. These crisis services specifically geared to children and youth and the challenges they experience. Next slide, please. So with any mobile crisis and outreach service here, what's going to happen when they show up? Well, they are going to assess the needs of the person with regard to their physical health and safety. They're going to do it where that person is in the community here. So the person doesn't need to come to them. The mobile crisis service will come to them. These services are available 24/7, and they're not telemed. They are coming out in person to meet you where you are to provide you the assessment and support you need. Next slide, please. As I mentioned before, MRSS services are a special subcategory of these mobile crisis teams that are specifically there for serving children and youth and their families right here, that will meet with individuals in the community during a crisis situation here with trained behavioral health professionals here and peer support as well here too for the youth and families here to be able to offer things such as screening and assessment, de-escalation of the crisis right here, and helping individuals coordinate getting connected to the services they need if something more intensive is needed than the services that the MRSS team can provide there in the community. Next slide, please. And our final cornerstone of this crisis system continuum are our emergency and crisis stabilization services, a place where you can go for help. These are services that are addressing individuals by providing ongoing follow-up support here for their crisis right here, helping people with either temporary, time-limited respite to deal with it here, or even potentially triaging them to more long-term care, such as an emergency department or an inpatient facility, if that's absolutely needed. The goal, though, always is if we can help the person de-escalate and feel better, getting them back to home would be ideal, that going to the ED or an inpatient facility is often a traumatic event for individuals here. So if you go to one of these, it's not like this is just a front door to the ED or the inpatient unit here. They will try and work with you there, and only if needed, if the individual needs more support than what they can give, help them connect with more intensive services here. Next slide, please. So crises, not just suicidality here, are very common, as we see among individuals at clinical high risk and those with first episode psychosis. If we look at people's pathway to care, to CHIRP programs here, many individuals, if not most, will access crisis services somewhere along the way before connecting with an outpatient program, whether that's either a mobile crisis team, calling 988, or potentially using a crisis respite service here. With individuals with FEP, first episode psychosis, we see similar information where over half of people will visit an emergency room before they get their psychotic disorder diagnosis. And over 75% on average have an ED visit between the receipt of their first diagnosis and before them actually connecting with the coordinated specialty care program to address their need. So these crises are common, and as we work with individuals clinically here, we see a need to not only be prepared to address them, but to address the crises, but also to connect with the services that are supporting these individuals in the community, because they are often connecting with these crisis services first before they connect with a specialty outpatient program like coordinated specialty care or a clinical high risk outpatient program. Next slide, please. So how do we establish pathways and connections with these crisis services? Next slide, please. One thing we can think about doing here in all of our communities is, of course, identify the crisis services in our communities at all three levels of this continuum of crisis services. So in our community here in Columbus, one of the activities we're always paying attention to is who are the crisis contact centers that are in our community? Who are the mobile crisis and outreach services? And who are the stabilization services that are available in our community? Sometimes these are run by one agency. Sometimes these are split up among multiple agencies here. And we want to connect with these providers here because there's a good chance that individuals in our program may experience a crisis at some point here, and we want them to be aware of these resources. And not just metaphorically, like they can Google it and find it out. Ideally, we want them to know when they come to us and get information about how you contact these services and what the resources are. That information is beneficial, we found, to provide to individuals with early psychosis, but of course also their family members and the clinical staff here that are working. So everyone is aware of the resources and can support the individual as much as possible when a crisis occurs here. On the same time, it's useful to connect with these services to let them know about the existence of your ESMI clinical program right here. The benefit of that, as I mentioned before, is most of our folks, either with clinical high risk for psychosis or those with first episode psychosis, are probably going to contact these crisis services at some point before they actually connect with our programs here. And if these crisis services are aware of our ESMI clinical programs here, they can help connect people to our programs, get them there quicker, and allow folks to access resources that may help them in the recovery sooner rather than later. Next slide, please. So one of the practices we have taken up at Epicenter here is being proactive about facilitating communication with crisis services with people that come into our program. One of the basic things we like to do is, if individuals are willing to, when they first join our program here, is when there's not a crisis happening at the very beginning, set up and get releases of information to allow us to have bi-directional communication with the crisis services here in our community. It's great to have those and great to get them done when a crisis is not happening. It's easy to get that done and quick. And if we never need to use them, that's not a problem here. But if we do, if a crisis emerges, it is such a wonderful thing to have that on file and know that we can talk with those providers right here so that we can help and work with them and the individual to help them in addressing the crisis that's occurring here. For those who live in states where you can have psychiatric advance directives, this is another thing you might want to consider talking about with people in your ESMI programs here, to collaboratively develop a plan before a crisis emerges for what that individual wants to happen, so that you can support them along the way in giving them the care that they want in the middle of a crisis right here. And for those not familiar with putting those together or what psychiatric advance directives is, SAMHSA a few years ago put out a very wonderful resource here, a practical guide to psychiatric advance directives that talks all about what they are, how they work. I believe it even talks about what states you can use them in, and I may be wrong about that point, and how to set them up with people here. These, again, are better. You would always want to get these set up before crises emerges. And if you never use it, it's not a problem. You've lost a few minutes of your day. But if you ever have to use it, it's really wonderful and a great way to ensure that in a crisis, the person is getting the care that they want and make sure that their wishes are respected in a moment where they may have difficulties or challenging expressing their wishes. Next slide, please. Now, let's say you live in a community and you do your community mapping here and you look around and you're like, we don't have all aspects of a crisis continuum here. We don't have the person to call, the person to come to, and the place to get help. SAMHSA has also put out guidelines here around helping communities set up crisis services. Really wonderful resources that you can check out if you find something missing in your community that is a missing part of that continuum of care. You can look here and get guidance and support on how it may be possible to work with people in your community to set these up. Next slide, please. So let's talk a little bit more about this bidirectional collaboration. What's the benefit of the collaboration a little more explicitly between these ESMI programs and the community crisis programs? Next slide, please. So early psychosis programs can benefit crisis services by providing them with specialty training that may expand their skill set that the crisis workers have. Things such as learning how early signs of psychosis may present during a crisis. If we're thinking about individuals with clinical high risk for psychosis who may not be experiencing frank, full-blown hallucinations and delusions, but are experiencing attenuated psychotic symptoms here, providing psychoeducation to the crisis service about what those might look like, and that there are clinical programs that are designed specifically to help people with those symptoms there can be useful here. Talking about how to engage individuals at clinical high risk or those with first episode psychosis and their families right here. It is challenging working in a crisis service. And you could imagine that if someone is experiencing a crisis but may also be struggling from delusions that people are trying to hurt them or out to get them, that may affect how they interact with the crisis service worker there here. Providing crisis service workers with the expertise that we have in our early psychosis programs around how to engage individuals who might be experiencing active symptoms of psychosis along with the crisis here will give them an important tool in their tool belt to more effectively navigate those sometimes challenging relationships. And of course, while I do think many of our crisis service workers are aware of trauma-informed care, this is another thing that is a hallmark of our early psychosis programs, and another place where we can provide additional education and trainings for our crisis service workers here to help them recognize and identify, recognize the way that trauma affects individuals here and provide their services in a way that is conducive and supportive to individuals who may have experienced past traumas along the way. Now, this training is not one directional here. Our crisis service workers have great expertise that they can bring over to our early psychosis programs and train our staffs on here. So just things like assessing for risk severity here. If I have a person come in and they say they're thinking about suicide, how do I determine if this is a serious risk, one that we need to potentially get them to the emergency room right now for here? Or do we potentially have other options that we should think about first here, depending on their risk severity here? This is what our crisis service workers are doing all the time here and are really have a strong expertise in with appreciating these gradations of risk right here. They can also help us with de-escalation techniques here. Someone comes in, is particularly agitated, angry, mad. These are skills that not all of our early psychosis clinicians always have as a strength in their clinical tool belt, but our crisis service workers deal with all the time. And they can help teach their tools of the trade to our staff and our clinics here so that we can be better with it if we ever need to use it in our clinical work. And finally, as crisis service workers have extensive experience collaborating with emergency medical technicians, police, firefighters, etc., during a crisis here, they can be a wonderful resource to train our local clinical staff here on how to effectively collaborate and coordinate with these individuals here during a crisis right here. Great skills for our early psychosis clinicians to have if they ever need to use them. Next slide, please. So I'll highlight a unique collaboration between crisis services and an early psychosis program that we are doing here in Franklin County, Ohio. We were very fortunate to be able to do this. This was funded by our Ohio Department of Mental Health and Addiction Services. Although as of today, I believe they've actually changed their name and they're the Ohio Department of Mental Health. But they provided us with funding to do a psychosis screening project with our local 988 call line, part of that SAMHSA continuum of crisis services that serves Franklin County, Ohio, where we're located here. We had talked about the idea of how can we help people who are in a crisis connect with early psychosis care early on and not have to wait. And so we partnered with our local 988 program, and we have trained all their call operators here after they've resolved the crisis. That, of course, is always priority one right here. But if the crisis is resolved, to offer the person, regardless of what they've said, an optional screener for psychosis and psychosis risk symptoms here. It's very brief. It maybe adds, we're trying to get data on how much it adds to the call, but so far the description has been, so from our operators, minimal, or maybe another like 2 minutes at most here. And individuals who screen positive, they connect them with us at Epicenter, where we will do a diagnostic assessment. We will be able to offer anyone who screens positive and is interested in getting this done, a diagnostic assessment within 2 business days of them calling 988. We'll bring them in and we'll see if it is a psychotic disorder here. And it could be first episode psychosis. It could be that they're clinical high risk for psychosis. It could be it's not psychosis at all. It's something else. Well, our staff will help them very quickly figure that out and then connect them with the appropriate clinical service in our community here, whether it's psychosis specific or not, so that we can get individuals very quickly into care right after they've contacted 988. I believe it's been a really wonderful partnership here, and I hope as this moves forward here, we'll be able to share more details about how this has played out with our local 988 team right here. Next slide, please. So finally, how do we address crises that emerge in clinical programs serving people at clinical high risk or experiencing first episode? When an individual walks in and is experiencing a crisis, what do we do to help them? Next slide, please. So one of the most important things we always need to do is assess for risk. And I'm going to do a big pitch that however you assess for risk, especially around suicidality, that we should all avoid that single question. There are a lot of suicide screeners that rely on a single question, something like the one on the top of the screen that says, have you ever seriously thought about killing yourself? Just a yes, no answer right here. The data is showing that these single item screeners are not great. And I'll highlight that with this study right here. So in this study, they met with, I think it was about a little over 1,500 individuals and asked them that question. Have you ever seriously thought about killing yourself? Some said yes, that's that first column on the left, and some said no. And regardless of if they said yes or no, they asked them a series of follow-up questions. These are all the things in the table. So have you ever had a time you thought I should kill myself, or ever thought maybe I should kill myself? Or you said, oh, I wish I was dead. Well, if you look over at the people who said no to that question about seriously killing yourself, all over on the far right here, we see really high rates of individuals endorsing these other questions here. Nearly 17% said, no, I've never thought about seriously killing myself, but I wish I was dead. High rates of that here. If you ask a single question, we often don't get a full answer of it here. So I'd encourage everyone to consider using more extensive measures for assessing suicidality, especially as you're first getting to know individuals here in your program here, and not rely on single items like this, because you will miss a lot of people who are experiencing true risk for suicidality often here. Next slide, please. And it's not just about ideation. It can be about having a plan for suicide. Same study, looking at individuals here. They asked them a question, have you ever made a plan to kill yourself? Asked 263 people this. About 2/3 of folks, so you see on the far right, said, no, never made a plan to kill yourself. But if you ask them, hey, have you ever thought of a method to kill yourself? Have you ever thought of a place? Have you taken any preparatory actions to kill yourself? We see high percentages of individuals who said, no, I've never made a plan to kill myself, but I've taken, 30% had made some preparatory actions to kill themselves here. Nearly 40% had completed 4 of the 5 planning components listed here, but said no to, have you ever made a plan to kill yourself? Again, single item questions just don't seem to do what we need to be able to really assess risk for suicidality. Next slide, please. The other thing to keep in mind here is it's not just using good in-depth measures to assess risk in crises, but when we're assessing, assessment should be repeated over the course of time. My colleague, again, Dr. Heather Wassler here at Epicenter, did a really nice study looking at individuals at clinical high risk for psychosis who were participating in 16 sessions of individual psychotherapy. And if you looked at the beginning, many studies, if you're looking at psychotherapy, like a clinical trial, you sort of get something at the very beginning and measure it again at the end, and you say, oh, it went up or down. Now, if we look just at that, at session 1, 24% of folks endorsed suicidal ideation. And at the end, at session 16, that was down to 16%. That seems great. Seems like it's gone down. But if you looked at when we asked them at every single session, because that's what we did during this year about suicidality here, we actually found that 60% of folks experienced suicidal ideation sometime during treatment here. So the data can be misleading if you only ask it infrequently here. You're going to miss a lot of the variability. Many of the experiences of suicidality and crises can come up quickly. And just because someone said, no, I'm not thinking about suicide last week, doesn't mean that that may not come up this week here. And if you go, like maybe someone might have, we didn't, but if you hypothetically did like this study and go 4 months in between, you're going to miss the majority of individuals who actually experience suicidal ideation by not asking about it frequently. Next slide, please. So one of the reasons sometimes people worry about asking folks with suicidality is there's this myth that if you ask someone about suicidality, it's going to make them more at risk to actually do it right here. And that myth is still out there, unfortunately here. And it often leads people to be reluctant to ask the question, have you thought about wanting to kill yourself? A really nice study by Blades and colleagues looked at this. And they found 18 studies where people asked people and talked with them about suicidality here and looked at, did they actually experience an increase in their suicidal thoughts and behavior after someone talked to them or not here? Well, actually, talking to them about suicide actually led to a small but clinically significant reduction in their suicidal ideation and a lower likelihood of engaging in suicidal behavior. So asking about suicide doesn't increase risk, or it doesn't appear to across these 18 studies here. And in fact, asking about risk may have some benefits. It may help people be able to talk about it, get support, get resources, and we may see reductions in the behavior, not increases. So avoid the myth that asking people is going to be problematic. Asking people is not, and it may be beneficial. Next slide, please. So there are a number of treatments that are out there to address suicidality. Unfortunately, most of the trials of these treatments have deliberately excluded individuals with psychosis from participating in them here. So does it mean that they're not going to work? I don't know if we can say that here, but maybe this is more of a plug for any suicide researchers out there, that excluding people with psychosis from these treatment trials here probably only reduces their likelihood of getting a treatment that may be beneficial for them here. There are several validated treatments that have come out as being effective for addressing suicide, again, in studies of people without psychosis. This is where we think about things like cognitive behavioral therapy for suicide prevention, DBT, and crisis response planning or safety planning. It's been called 2 different names. Next slide, please. Crisis response planning, I'll mention a little bit more in detail because this is a very useful intervention and we deploy this regularly here in our early psychosis program here. It's a very brief intervention that can be done in 1 session with an individual who is or has experienced thoughts of suicidality, where we're going to identify warnings and triggers, strategies that they can employ to reduce distress or distract from that situation, who are the supportive people they can contact, the numbers of professional services like our crisis service lines that they can reach out to if they need to, reasons for living, and also plans around means restriction, meaning how can we keep items that may be used in a suicide attempt away from the person here, like keeping guns in a locked cabinet that they can't access here. And this very simple single intervention here across randomized trials has been shown to reduce suicide attempts by 45 to 75% just as a single treatment, not with anything else right here. It's a very powerful, but also not difficult or intense intervention to do. Next slide, please. SAMHSA and others have put out really nice worksheets to help guide you through this safety plan training or crisis response planning here. This is the example of the SAMHSA form here. This is something that I would sit down with an individual who is experiencing or has experienced suicidality, and we're going to write this all out. And this is going to be their resource to carry with them here. So when a crisis emerges, they don't need to think then, what do I need to do to help? They have a plan that's written out and they can just enact in that moment right here to help support them. Next slide, please. We're getting near the end, so I'm going to be a little brief about this here, but I'm going to do a plug for Dr. Liz Thompson out at Brown, who wrote a really wonderful paper about how to personalize and adapt safety plan for individuals with early psychosis specifically here, considering things like psychotic symptoms and how they may potentially be something that you want to help the person think about coping skills for, but also prepare to address as part of their safety plan right here that may not be included in just sort of your standard safety plan that's used with someone for psychosis. Great article. I found this very useful. I encourage others to check it out. Next slide, please. With our psychosocial treatments that are more intensive, things like DBT, for example, here, these interventions have been shown among individuals without psychosis to be very potent in reducing suicidal ideation right here and behavior. People who participate in these services here reported reduction in all of those, including risk of dying by suicide right here. So for people who maybe need something more than a safety plan, services like DBT may be a potential more intensive thing to support them. Next slide, please. And then when we think about individuals with psychosis specifically, one intervention that has actually been examined specifically among individuals with psychosis to address suicidality is clozapine, one of our antipsychotics that is usually used for treatment-resistant schizophrenia, but also has been shown across studies to result in lower rates of suicidal behaviors among individuals with psychotic disorders compared to people who are receiving other antipsychotic medication here. So while our psychosocial treatments have not included people with psychosis in their studies here, and we can infer potentially that they're beneficial, there's good data that clozapine for individuals with psychosis can be a useful consideration to address suicidal behaviors. Next slide, please. So what do we take from all this here? Individuals at clinical high risk and those at first episode psychosis are at elevated risk for a behavioral health crisis, compared to people with longstanding psychosis and also compared to people without a psychotic disorder here. That there are real opportunities for our early ESMI clinical services to collaborate with crisis services here to not only make sure that our staff are better trained to address these needs of individuals with early psychosis here, but also to make sure that we are best prepared to help give the information and support to individuals coming to our programs about how to navigate crises if they should occur here. And that in our programs here, we should be prepared to regularly and repeatedly be assessing for risk for crises, and that single questions and not asking about suicidality frequently are only going to lead to missing people who are potentially experiencing this crisis. So thanks everyone for your attention. Dr. George, I'll pass it back to you here for the end. My email is here. If anyone, people are more than welcome to send emails if there's anything I can be assist with.
Great. Thank you so much, Dr. Brightboard. That was a fantastic presentation with very, very useful information. I think that that's certainly reflected in the chat. So right now, what we're going to do is we're going to have a little bit of a Q&A to go through some of the questions that people put into the Q&A and chat feature. There are a number of different questions about measurement and assessment. So one question we'd like to ask is, what are some validated measures to assess for suicidality among individuals with first episode psychosis and individuals at clinical high risk for developing psychosis?
Yeah, there are a lot. I'll talk about two just because they're the two I'm most familiar with here. One of them, of course, is the Columbia Suicide Severity Rating Scale that I imagine many people are familiar with right here. That has been used to assess risk for suicidal ideation behavior. If anyone is not familiar with this, it is available for free online. And there are also free trainings online for anyone who wants to learn how to administer that assessment accurately here. Another measure is the SITBI, SITBI, and you'll forgive me, I'm forgetting off the top of my head. Was it Self-Injurious Thoughts and Behaviors Index, I think is what it stands for. The SITBI is a much more intense is long, that's probably the more accurate word, assessment than the Columbia. But it gets much more in depth. It gets much more into non-suicidal self-injury, getting both lifetime risk and current risk right here. Those are the two that we use regularly in our program. That's why I'm most familiar with them here. But they're probably, at least anecdotally, the two that I've heard most ESMI programs use if they are using a structured suicide assessment.
Mm-hmm. Great. Here's one about 988. How could I learn more about working with my local 988 program to begin screening for psychosis and psychosis risk?
Yeah. The best thing is, I'd say, is if you haven't already, reach out to them and talk about it. I'll do a plug for our 988 program here at North Central Mental Health Center, the one that we partnered with here. We reached out to them about this, and I was worried, like, they're doing so much and working hard and dealing with crises. The last thing they want to do is do this. But I met with them. I said, hey, we want to do this. We thought we could help. We could get people to care more sooner. We could offer them this quick diagnostic assessment. It may be useful. And they were like, we're in. Their motivation was that, maybe I forgot that their motivation in the end was the same of all of ours. They wanted to help people. So step one, I would say, is connecting with them and reaching out for it too. If anyone is interested in the screening screener we've developed, or how to use it, you're more than welcome to reach out to me. I'm not going to say it's the perfect screener, but it's the one that we use. And at the very least, if it's helpful for anyone, it can be a starting point for something that we found is very reasonable and quick for a 988 program to integrate into their calls without adding real burden for the staff beyond the work that they're already doing.
Great. Here's another one about different diagnoses and how they may relate to one another. So is there an increased risk for suicidality or developing a psychotic disorder among adolescents with substance use disorders or adolescents who have ADHD? How do those relate?
Yeah. Well, and as you might remember, just in general, in adolescence, that period, there is a bump in risk of suicide for everyone here, regardless if you have a mental health concern or not right here. Suicide or substance use is a risk factor for suicidality. So I would imagine that we would probably see an increased risk of suicide among adolescents who are abusing substances here. The ADHD literature, just being honest, is not one that I am as well familiar with as the psychosis literature here. So I don't know. But I would say we're just thinking about that this developmental stage is a high risk period in general right here. And when I work with youth in that age, regardless of what the diagnosis is, I'm always screening for risk just in general, because I know this is a time where we unfortunately see higher rates of it.
Great. I think we have time for one more question. So when you're talking about a mobile crisis team, who can refer to a mobile crisis team? So for example, can a parent or a loved one call a mobile crisis team to do a welfare check if they suspect that a loved one may be experiencing some suicidal ideation? Or does it require the individual who's experiencing that crisis to request assistance?
That is a great question. Anyone can call, and that's what they are meant to do. Now, like anything, it becomes a little challenging if the person is an adult, the person experiencing the crisis is an adult, and they don't want services or care. But anyone can access these services here, including, for example, I'll say this, schools. So teachers, school administrators, if they have a child at their school who's experiencing a crisis, this happens, it's one of the reasons we have a large MRSS deployment in Ohio. Schools can call directly and say, we have a child who is struggling in this moment. Can you send someone else for help? So anyone can call to get support in those moments here.
That's great. Okay, so we only have 2 minutes left, and we just have a couple of more slides to show you. Thanks again, Dr. Brightboard. This is fantastic. So if you all would like to share how you felt about this webinar and provide your feedback, please click on the QR code or look at the link in the chat. We'd love your feedback on how the webinar was useful to you and how you think the information could be useful for you in your work. So please feel free to click on that. Just a quick plug, a week from today, on Wednesday at 12 p.m. Eastern Time, we have another webinar. This one is on suicide prevention best practices for individuals at clinical high risk for psychosis or those experiencing first episode psychosis. So you can register now. We'll put the link in the chat so you can go to that and register for another fantastic webinar. So we will put the QR code back on so that if you have time, we would love to get your feedback on this webinar and hear your thoughts. So with that, I just want to say thank you to all of you for attending. It's a fantastic webinar, and we are so pleased that you could join us. So have a great day. Thanks very much.